Welcome to the Science Chick Report. I'm Dr. Kathleen Kendall-Tackett, and tonight we're going to be discussing something that I think is really important for healthcare providers, and that is looking at what was the effect of COVID on healthcare providers, on our workforce, basically in healthcare. And it's something that I think we really kind of haven't discussed very much, but was, a huge concern in a number of different studies. In an article that I recently wrote, I'm doing the revision of it right now. So this is literally hot off the press. So hopefully this article, but the plan is this article will be out in December, but I'm doing the revisions on it right now. But I wanted to talk a little bit about kind of what we found when we went through and looked at all the research on the effect of COVID on healthcare providers. And we were particularly looking at a construct called moral injury. Now, moral injury is actually a pretty interesting construct, because it's like I said, I'm the editor in chief of the journal Psychological Trauma for the American Psych Association. And so the moral injury articles we've been getting for, at least the last 10 years or so. And basically what it is it's like it's not diagnosis at this point, but it was a recognition that oftentimes people who had been in combat were experiencing symptoms that were kind of above and beyond post-traumatic stress disorder. And it really kind of dealt with issues of right and wrong. Did the soldier participate in something or witness something that they believed to be wrong? And that actually could cause symptoms in addition to post-traumatic stress disorder. PTSD is kind of based on fear and danger, but moral injury is looking at the idea of guilt and shame. And so we really hadn't applied it to healthcare providers before COVID. Now, back in 2019, I actually did write an article about it because I was recognizing that something that, Dr. Cheryl Beck's research was calling secondary trauma in maternity care nurses was really more likely moral injury. They were describing, witnessing terrible things, and they were using language like, I felt like I was witnessing a rape. So this was something really that they felt that patient care was very severely compromised. And in fact, they were witness to it, but they couldn't do anything to stop it, because they were not in a position of power. And so something similar happened during COVID. Oftentimes that there were the powers that be, and even, the primary providers who usually kind of run the show were not able to because the policies were overriding them. And so again, some of these policies, and there was kind of a collapse in terms of, institutional support. And yes, it was an unprecedented event, but hopefully it's something that we can learn something from. Okay, so let's talk a little bit about what moral injury is. It kind of has to do with the betrayal of something that's right by somebody who holds legitimate authority in a high stakes situation within events outside of the person who's suffering's control. And so again, we see that they overlap quite a bit, but they are distinct conditions. And, oftentimes we can see, when we look at kind of the timing of the conditions, oftentimes moral injury may precede symptoms of post-traumatic stress disorder. But this is still new enough. We don't necessarily know exactly how these two interact. Okay, but if you think about it, soldiers and healthcare providers actually are very different, obviously. The healthcare provider's whole mandate is to help and to heal, versus soldiers are there to protect and in some cases, harm and use lethal force, against other combatants. And so again, at the surface, it doesn't seem like that there's that much in common. But if you think about it another way, one of the characteristics of moral injury is that it is a high stakes situation with life or death consequences. So yeah, that actually does apply to healthcare providers. Also, too, something that's important is there's a command structure, particularly within, say, hospital settings. That there's certain people that are in charge and that certain people that are, commanded to actually carry out orders or actions of, say, the physicians. Oftentimes the nurses then are in a position where they have to kind of carry out orders, even if they don't necessarily agree with them. Okay, so that's kind of just in a normal setting. So what happened during COVID? What happened during COVID is the policies then took precedence over all of the healthcare providers. So the healthcare providers that were normally in charge, like physicians, suddenly found themselves not. Okay. And so that was one of the things that kind of opened them up to this moral injury. So what we did is we've actually looked at 36 articles that had been published, during the time of COVID and immediately after. And honestly, the quality of the articles varied because it was such a kind of an unusual circumstance. And I think people were honestly scrambling to try to address it and try to figure out what was going on. But they knew that something really bad was happening to our healthcare providers. And so basically, we were looking at providers on the front lines who described a situation that was dire, that they were being exposed to a dangerous disease, often without adequate protection. They didn't feel like the information was very reliable or consistent, that the resources were limited, and that in the end, they could not provide good care because of these problems. And so this is actually what one physician described. She said, as with soldiers in war, we know that as soon as we stop doing, we will start feeling. The deferred processing of grief and trauma and betrayal for the patients we've lost, the tragedy we've witnessed, and the risk foisted on us by failures of organizational foresight will threaten to overtake us. It is hard to know where we are safe. And so again, that was a very, I think, forthright and dramatic kind of telling. And that really did kind of put it kind of in a language that I think a lot of military providers could really understand. And nurses said that nurses were simply unable to provide this level of care. Many nurses are taken by a sense of helplessness, question their abilities, and are forlorn and frustrated at the bedside of a patient who is cut off from family and friends, dying alone. And for many of the healthcare providers, that was something that was really, really difficult to be a party to. It was this feeling like, these poor patients were dying and they couldn't have anybody around them, and that even the simplest wish was denied. But this was not just for people dealing with the front lines of COVID. Oftentimes the COVID precautions actually created their own problems. And that was actually true in maternity care. When there was, women laboring alone, there was separation of mothers and babies, sometimes for up to 2 weeks, and so there were many providers who really thought that this was terrible. And this was what actually Horst in Switzerland, she gathered a bunch of comments together from maternity care providers. And this is what she concluded. She said, in extreme cases, staff can feel that they have become instruments of inhumane treatment of women and babies, active perpetrators of psychological and physical harm, in complete violation of their moral norms and practice standards. So again, I think she was very much describing a moral injury and the things that were happening. Okay, so what were some of the effects of this? Well, they were pretty shocking when you started looking at them. So anywhere from 30 to 60 or even 70% of providers were affected by what happened during COVID. And the problem is, I don't think people are really honestly addressing it. Okay, so this is an example. This was a study from Fisher et al. 2022. They looked at the experiences of 786 frontline healthcare workers in New York City. And they looked at two time periods in the wake, in the peak of COVID and 7 months later. And they said during the peak, 67% reported moderate to high levels of moral injury related guilt, with 60% reciting family related guilt and 29% citing work related guilt. And the family related guilt had to do with their fear of transmitting the virus to loved ones. And work related guilt often stemmed from the limitations and challenges in patient care. And moral distress was significantly associated with moral injury related guilt over time. But those who received greater supervisor support were less likely to have a sustained effect of work related guilt after 7 months. So this does actually highlight that supervisors actually do make a difference and can make an incredible difference. This was another study. This was from the US, And this looked at the experiences of 121 critical care nurses. And, one of the themes that actually really emerged, and this emerged in several of the studies, but it was a really striking finding, was that so many of these providers felt betrayed by their team, betrayed by their institutions, their organizations, and the field itself. And so there was just this really kind of very tangible sense of that. And in fact, that probably overrode many of the other effects that they reported. Okay, so this one here with the 121 critical care nurses found that 60% felt betrayed by their institutional leaders. And it was institutional betrayal characterized by abandonment and broken trust, was strongly associated with moral injury and traumatic stress symptoms. And the nurses reported that organizations failed to protect them, which eroded their trust and wore down their resilience. This was another study from the U.S. This was actually from 46 Veterans Affairs healthcare workers during COVID. And they found betrayal was particularly harmful when it affected patient care. This is what one nurse described. She said, "I was desperately trying to do what I felt was the right thing and the best for my patients. I felt like my coworkers and I were betrayed and abandoned, left to do more with less and less." Another nurse said, "We got a lot of lip service and no actual action. It was demoralizing and disheartening." And they even described some policies that really had very negative effects on patients. And so because they witnessed this, it had negative effects on them. And there was one case in particular that was mentioned where a patient was asked to see her 4-year-old daughter before she died and was denied this because of the visitation restrictions. So they felt that that really definitely influenced the patient care. But also, too, this was a study from the Netherlands and looked at a group of ICU professionals. And they actually said that many felt betrayed by society, the government, healthcare organizations, and they perceived that the lives of frontline staff were undervalued, feeling that hospitals and policymakers failed to protect them during the crisis. Okay, in the UK, there was kind of a similar sentiment. This was a qualitative study looking at the National Health Service, and this was actually nurses. And they said that the staff felt abandoned by the institutions and left them with insufficient support and protection, which betrayed their trust. They also felt expendable, as this one nurse described. She said, "If I die, they don't care. They'll just get somebody else in my shoes tomorrow." The hospital staff described management as dishonest. They felt misled and unsupported, which contributed to their disillusionment. So, one of the things that was kind of a surprise finding of looking at all these different studies was finding that burnout for these healthcare providers in many cases was the end state. Now, you never ever see burnout described when you talk about moral injury in soldiers. And yet, we were seeing burnout as being something that was very relevant to healthcare providers. And in fact, this study by Newsma in 2022 directly compared 625 veterans that were post 9/11, so they had gone to Afghanistan, compared to 2,099 healthcare providers treating COVID. Okay, what was interesting is there were a lot of experiences that were similar between those two groups, but only healthcare providers reported burnout. So the healthcare provider group included physicians, nurse practitioners, physician assistants, and other diagnosing and treating providers working in high-risk settings. Okay, so they said the veterans actually had overlapping symptoms and both had higher depression scores and lower perceived quality of life because they'd experienced moral injury, but only the healthcare providers experienced burnout. And again, it really kind of makes sense because you never hear about soldiers talking about burnout. But what you do hear is kind of, if you look at the PTSD diagnosis, there is this numbing symptom that is common. And so actually, I think that that's very similar to what was happening. We're using just different names for the same thing. But it's this kind of feeling of disengaged, lack of empathy, and, sort of a, not kind of being present, not having, sort of looking at people with empathy and concern. But, do want to say that there was actually some good news that came out of these studies. Some of the studies actually found resilience. Okay, so some of the things that actually fostered resilience were things like team management, particularly honest communication and visible support from management and collaborative problem solving. And so these were things that were often lacking in many of the studies. But when they were there, they actually helped the staff weather the storm. So it just kind of goes to show that good management is always important, always. And they said that honest communication includes trust in leadership and transparent and honest communication from supervisors. And visible support from management included valuing healthcare workers and protecting the staff by doing practical things like providing protective equipment. Okay, so what can organizations learn from this? Because there were some places that were actually successful. And so we want to say, okay, let's learn from them and let's make sure that these things are in place next time. Okay, so supervisor support and valuing healthcare workers fosters resilience. Okay, particularly in high stress situations. And this is really important. So it kind of goes back to what I've always said. Good leaders are a gift from God. They just really make such a huge difference in the team. So one of the things that they need to do is they need to prioritize staff safety, well-being, and morale. Okay, so these are really important. These are things, because if people say, well, what can we do? It was a crisis. Well, we know that not every organization had these problems. And so, again, we want to kind of learn from them. So, want to make sure that we meet the basic needs of staff by providing things like food, drink, and rest. We want to make sure that the staffing is actually adequate so that people are not just working themselves right into the ground. That's something that was really important. Okay. And also that we want to make sure that the staff are listened to, and that they be able to do the things that make them feel like that they are providing good care. So the organizations that were successful at this made sure to meet the staff's needs at kind of every junction. And again, it kind of goes back to this idea that, staff protection is really important and people actually can do it. So I'm hoping that you find that there was something here that was useful to you. To organizations, I'd really like to speak to this because I'd say, I would really recommend that you assess the members of your organization to see where they are. Because oftentimes the healthcare providers don't necessarily speak up, but they're really suffering, and they're finding too that their empathy is lower. They don't have the empathy toward patients. And if you think about it from two things that organizations care about, patient satisfaction and staff retention. I want you to really say that these are things that organizations need to get behind. But individuals, you need to kind of recognize, do you have some symptoms from this time? Do you need a way to process them? You could be processing them on your own. You could be processing them with your group. Let's talk about what were the terrible things that happened, and how can we do better moving forward? That's really kind of one of the best ways to address moral injury. But also, can you write about your experiences? Can you talk to a therapist about them? Really kind of help you understand where you are and what you experienced. Your individual experience was important. And so, I would really encourage you to be open to addressing this. And again, like I said, just even writing about the experience actually can really help. But what we want to help you do is become the best clinician that you can be, and that you moving forward can continue to provide good quality care. And to the organizations, I want to say apologize for what happened. That really goes a long way toward, repairing relationships and reestablishing trust with your staff and your team. Because the fact is, you need each other, and so again, I want to say this was a terrible thing, but I hope we all can learn something from it. And again, even just from the theoretical standpoint, learning that the moral injury construct, I believe, can be applied to healthcare providers, but there are some specific differences. Particularly that betrayal and burnout seem to be two of the really big factors. So with that, I'm going to wrap up for this session. I want to say I hope this was useful to you. I am going to actually make the paper available. I'll have a link for it up on ResearchGate so you can take a look and read the research for yourself. Anyway, I wish you great success. Thank you for all the work that you do, and I will see you next time.